This is Dr. Robert Watkins, orthopedic spine surgeon to professional athletes and creator of the Back Doctor app. Today's podcast is on spinal injections. We'll be talking about epidurals, facet joints, nerve root blocks, injections into the disc. Injections are typically done for pain, either back or leg pain, or neck or arm pain, cervical, thoracic, lumbar injections. So the first question is where's the shot actually going? And an epidural injection is the gold standard for a spinal injection. And when I tell people they're going to get an epidural, the first thing they do is they look at me and they go, first of all, I'm not having a baby. Second of all, I'm a guy. So why are you going to do an epidural on me? And so first we want to clarify what's the difference between having a baby, getting an epidural for pregnancy, and an epidural for pain relief. And basically it's the same space. There's a sac that covers the nerves called the dura. It's kind of like this balloon that has spinal fluid in the middle of it with the nerves in the middle of it, and that protects the nerves and keeps the spinal fluid in there. And outside of that space is epidural. In Latin, epi means surrounding or outside. Outside of the dura is epidural. So it's not in the dural space, which could give you a spinal fluid leak. It's outside of it. And therefore, it's a safe place to put the injections, and it can calm down pain and inflammation from the nerves. And so that's an epidural injection, and that's the gold standard. And typically, epidurals have been done with anti-inflammatory steroids, such as prednisone, methylprednisolone, depomedrol, Kenalog, cortisone. These are all different types of anti-inflammatory steroid. And the benefit of doing the epidural is when you put the steroid, this anti-inflammatory steroid, in the spot where the pain is and the problem is, typically it can be more effective and last longer than if you're taking it by mouth. So it's the same medicines you can take by mouth. The problem is when you take a pill by mouth, it's got to go through your stomach. It's got to go through your whole body, which is kind of crazy that you're going to take a medicine that's going to go through your whole body just to affect this one spot in your back. And that's where the shots can be more effective because it's targeting the medicine right at the point of the problem. Therefore, it can be more effective and it can last longer. A lot of times the shots can last for 2 to 3 months, whereas typically when you take a pill by mouth, it'll stick around for 6 to 12 hours. So epidurals are done most effectively for nerve pain. So if you get a tear in a disc in your back and it releases acidic chemicals that irritate the nerve, or if you get a disc herniation, or if you have stenosis, something putting pressure on a nerve and the pain going down the leg or down the arm, the epidural can be very effective to get rid of the inflammation and the pain from that nerve. So nerve pain is typically the most effective treated by the epidurals. Epidurals can also help pain that comes from the disc itself or the facet joint. And so the disc itself, 80% of all the biomechanical activity is occurring through the disc. And so most pain that people have in their back is from micro tears in the disc from the annulus, which is the outer part of the disc. So typically, if you throw your back out, you have a lot of back pain, it's because you've hurt the disc. And the epidurals put the medicine in around the disc, but they don't actually penetrate the disc. So it can still be helpful because it can calm down a lot of the nerve pain that's around the disc. The disc is richly innervated as well as the spinal nerve goes past it, so it can calm down the pain from both of those nerves. But at the same time, it's not healing the disc and it's not necessarily very effective for disc pain because it's not injecting the disc itself. And furthermore, the facet joint, for every disc in the front, you have 2 facet joints in the back, and they can be a source of pain too, but they only see about 20% of the stress in the lumbar spine in your lower back. Therefore, they're not as likely to be the source of the pain. An epidural can help pain from the facet joint because the little nerve, the medial branch, goes up and innervates the facet joint. Well, the epidural can block that nerve. And so epidurals are generally the best shotgun approach because it treats the spinal nerve, it treats the disc pain, it treats facet joint pain. It can treat everything, but overall it's most effective for treating nerve pain. So there's different ways to do an epidural, which further confuses patients. The old school way was just bend somebody over in the office and put the needle right in their back and inject their back, and that was called a translaminar epidural. It goes in between the lamina. And, that can be a little dangerous because you're not doing it under x-ray guidance, so you don't exactly see where the needle's going. Now, if you do a lot of them, you get very good at it. And the epidurals that are done for women undergoing pregnancy, undergoing delivery, is done usually through a interlaminar approach, similar type of approach. And so anesthesiologists and pain doctors who do a lot of them get very good and do it very safely without x-ray. But we tend to use x-ray and a fluoroscopy machine because it shows us exactly where the needle's going. We inject dye, take an x-ray, it shows exactly where the dye is, and it can typically be a safer and more accurate way to do the shots, although that has not necessarily been proven. So the old school way of doing it in the office can be effective with somebody with a lot of experience, but there's also a risk for a spinal fluid leak because if the needle goes too deep, it doesn't stay epidural, it goes intradural, which means it goes into the dura, which is where the spinal fluid is and the nerves are, and you can get a spinal fluid leak, which can result in a severe headache, nausea, vomiting, and have issues, and then potentially have to undergo a blood patch, which takes some blood out of an IV out of your vein and injects it in that area. It forms a blood clot to seal it. So typically they're treated and treatable if you do get a spinal fluid leak, but obviously that's less than ideal. And doing them in the office with somebody bent over the exam table can still be done safely, but generally in America, doing it in a fluoroscopy or operating suite or radiology suite with x-ray guidance can be more accurate and safer. So that's the translaminar epidural. Another type of epidural is the caudal epidural, which means going from the bottom. And basically, as your sacrum comes down and then blends into your tailbone, there's a sacral hiatus. There's a hole in your pelvis, in your sacrum, where the needle can be injected and inserted up into that area. And then the medicine can be injected from the bottom, which can go up and flood L5S1, L4-5, even up to L3-4 potentially. And the two bottom discs in your lumbar spine are the most likely to be painful. So these caudal epidurals from your tailbone can really flood the main areas of most people's back pain. And again, it can be done very safely and effectively. Sometimes it's done without x-ray. I personally do them with x-ray because why not? It makes it much more accurate and safer in my hands. I can actually see the hole in the sacrum, put the needle up, aspirate, make sure there's no blood or spinal fluid, and then inject some dye, take an x-ray, see exactly where the dye is tracking. I can change my needle, change the direction if the dye isn't flowing right where I want it to be, and then get it right where I want it, and then inject the medicine. And the medicine is a combination of Marcaine, which is the numbing medicine the dentists use, with an anti-inflammatory steroid like prednisone, and with saline, which just adds some extra volume, which helps wash out a lot of the neurotoxic chemicals that are causing the pain. And then a third way to do epidural injections is a transferaminal epidural. And this is what I tend to do the most and is probably the number one type of epidural done across the country these days. And the transferaminal means going through the foramen. And the foramen are the windows out on the sides of the spine where the spinal nerves come out. So typically we'll use an x-ray. We'll come in at about a 30-degree angle. And that allows us to come underneath the nerve and from the inside out into the spinal canal, which has a much less chance of getting a spinal fluid leak because you're not right in the central part of the dura where the bad stenosis is. And additionally, it allows us to really target specific nerves where we think the pain is coming from. A nerve root block is very similar to a transferaminal epidural. In my hands, it means that I'm typically just going to target one nerve. And as I inject around the nerve, I'll actually ask the patient, does this stimulate pain in a similar area where you typically get your pain? And so they'll give me feedback as I'm doing the shot. And it's not very painful. We still give people a touch of a twilight anesthetic, so it kind of takes the edge off. And most people don't even really remember the shot a whole lot. But it allows us to keep them awake and keep them talkative where I can get some feedback. And if I inject around the nerve, if it stimulates the nerve and if that reproduces pain, the same pain that the patient typically gets, it can help us with the diagnosis to know that nerve is probably the source of the pain. The injections are not 100% diagnostic, which means that it may be the painful nerve, the actual source of the pain. I may inject it and it may not help and it may not reproduce the pain. Or the flip side is sometimes I can inject, it may reproduce somebody's pain and we think it's that nerve, but it's actually not. So nothing we have is 100% diagnostic. The MRI, the x-rays, the exam, it's more a combination of multiple sources. The more these overlap and point to the source of the pain, more likely we are to know what's causing the pain and therefore whether surgery will really help or not and to what odds. And the diagnostic nerve root blocks can help in that process us delineate which nerve is the source of the pain. So a nerve root block is very similar to an epidural. It's the same process, same medication. It's just typically for me, I keep the patient a little bit more awake, get some feedback, and I'll typically just inject one nerve. Whereas with a transferaminal epidural, I may do a couple injections, which may hit multiple nerves because I'm really just trying to give the patient some pain relief. It's not really for diagnosis. It's more for pain relief in hopes of being able to do physical therapy, in hopes of being able to buy time and hopefully avoid having surgery. So those are the different types of epidurals, the transferaminals, the nerve root blocks, the caudal epidurals, and the translaminar epidurals. The other type of injection that's done a lot is the facet joint injection. And as I mentioned before, the facet joints, which are in the back, they only take about 20% of the weight and the biomechanical activity. So it's not typical that they're a significant source of pain, but sometimes they are. We can get a CT bone scan, which can check metabolic activity in arthritic joints and discs. And if it really lights up on the facet joints, it's more likely they're a source of pain. And therefore, facet injections may be helpful. And basically what we do is we block the nerve that goes to the facet joint, which is the medial branch that comes up, and then I'll also inject some medicine into the joint capsule itself. So we really block the nerve and the joint at the same time. Shots are extremely safe and quick and easy. The risk of a spinal fluid leak is almost zero because you're not going down into the canal. You're staying superficial and just blocking the joint. And so it's a very safe, quick, easy procedure. The biggest downside is a lot of times they're marginally effective because they don't help nerve pain and they don't help disc pain, which are typically the main sources of pain. They just help facet joint pain. But basically, if the facet joint injections do help, then there's a secondary procedure that may be effective called a rhizotomy, radiofrequency, ablation. They're all the same terms, which basically means you go in with a probe and with a high temperature and burn this little medial branch nerve that is innervating the facet joint, so it gets rid of the pain sensors from the facet joint. It doesn't cure anything. It doesn't fix arthritis. It just gets rid of the sensor so that you don't feel the pain. And there's some risk in that to the degree if you get rid of this pain sensor, well, then you're not going to feel the pain. Then you may go out and play golf and do all these things and continue to aggravate and deteriorate your facet joint because you don't have the pain sensor telling you not to do it. But overall, it's a very safe procedure, and this radiofrequency ablation, rhizotomy, is a secondary step. If the facet joint injections have been positive and have been helpful, you can have this procedure done, and the benefit of it is it can last for 9 to 12 months rather than only 2 to 3 months. So it can last longer, give people up to a year of pain relief, which can obviously be really helpful. The reason why the pain relief goes away is these little nerves can grow back. So the nerves grow back and the facet joint gets reinnervated and the pain can come back. And so it's not a great procedure, but it serves a middle ground for people who have failed all conservative management. They've done physical therapy and chiropractor and acupuncture and tried everything, and they're still having a lot of back pain. Well, instead of doing a fusion, if we want to try and avoid a fusion, doing the facet injection, then the rhizotomy, radiofrequency, or ablation may give them a year of pain relief, which could avoid having the fusion, and that's definitely a benefit. So then the last component is injections into the disc itself, and that's rarely done because the disc itself, to inject the disc, you have to penetrate the disc. The outer part of the disc is this woven basket, the annulus. It's providing all the stability. It's literally connecting the bones together. It's connecting your vertebrae together. So all the motion, every time you move and breathe and walk and talk and twist your back, you're stressing that annulus. It's doing a job all the time. 80% of all the biomechanical activity and the weight goes through the disc and through this annulus, so it's the real workhorse for the spine. So when you have back pain, it's usually the disc is the source of the pain. And the problem with trying to inject it is you have to stick a needle into the disc and penetrate this annulus in order to do the injection. So by definition, you're traumatizing the disc in order to do the injection. So how many times can you penetrate a disc with a needle to inject it before you start to cause problems in the disc itself and lead to degeneration of the disc because you keep poking at it and keep degenerating it? And so injections to the disc have that problem. Another problem is the disc itself is a harsh environment. The disc is hypoxic, acidic, has a poor blood supply. And what that means is acidic means it has a low pH. So if you put substances into the disc space, they can just dissolve because it's acidic. It's hypoxic. It does not have a good oxygen supply. So again, if you put some cells in there and some live stem cells and hope they're going to take off and regenerate a new disc, well, there's no blood supply. They may just die right away. And the last component is that it has a poor blood supply. The blood actually comes from the bone next to it. It just diffuses across into it. It doesn't have a very good blood supply, and therefore a lot of things that go into there end up dying because it's such a harsh environment. So the reason why the injections in the disc are not great to date, because you have to penetrate the disc, you have to traumatize it to inject something in there, and then whatever you inject in there is probably going to die within a couple days. And then the third component is the disc actually is made up of two different substances. The outer part of the disc is the annulus. It's like that woven basket tough material. The inner part is the nucleus. Well, it's more watery and shock absorbing and gelatinous. And, the ratio of proteins in these two parts of the disc are exactly the opposite. They're almost totally different structures. So when you talk about injecting something into the disc to heal the disc or to decrease the pain, well, which part of the disc are you healing? The inner part, the nucleus, or the outer part, the annulus? And they're totally different. So that's why injecting discs is such a difficult topic that we haven't made a lot of progress as of to date. It is part of the future. In the next 20, 30, 40 years, this is a huge industry. It's a multi-trillion-dollar industry. Everybody has back pain. Go on, watch late-night television. You see braces and balms and rubs and all sorts of electric stimulation in order to treat people's back pain. Spine surgery is a huge field and industry that takes a lot of the national government money in any society. So it's a huge field, and the research is being done, and there will be a solution. But there's nothing to date, and it's a far ways off because of this multi-layered problem. And the third component is actually, which is really important, is as discs degenerate, they lose some of the water content. They get darker on the MRI. Then they'll start to collapse down. They'll get micro tears in it. The disc will bulge out. And then the stress isn't getting picked up by the disc, so it gets transferred to the bone. So you'll start to see irregularities in the bone. We call them modic changes. You see inflammation, edema, potholes, irregularities in the bone because the bone, it's kind of like bone on bone in your knee. It's bone on bone in the disc, and the disc starts to get arthritic and develop all these sclerotic changes. And then you can start to get slips where one bone will slip forward on the other one, which is a spondylolisthesis, or a scoliosis because it gets tilted one way or the other. And the problem with this is if you're going to inject something into the disc, well, at what stage of this degenerative process are you injecting the disc? Because if you're waiting till the disc is really painful and obviously degenerated and arthritic, and you're trying to inject some medicine into the disc space, it's too late. The disc is already shot. It's biomechanically shot. It's already tilted and slipped and sclerotic. It doesn't matter what you inject in there, and it's acidic and hypoxic and no blood supply. Whatever you inject in there, they're just going to die, and it's not going to fix the biomechanical structural problem. So most discs that we're operating on and that we're really seeing in the office and treating with surgery are so far gone structurally and biomechanically, it doesn't matter what you inject in them. It's past that point. So what that means is you got to back up. So you need to inject discs with a biologic or with some type of substance. You got to inject them really early in the process before the biomechanical degeneration sets in. So what does that mean is you got to start injecting discs that are just dark. So you get an MRI and somebody has one dark disc and they've had back pain for 3 to 6 months. Those are the discs you should inject that have the best chance of helping, because it's so early in the process, you may actually be able to help it and retard the process and stop it from going down this degenerative cascade. But you got to inject that disc early if you really want it to be effective. Well, what's the problem with that? The problem with that is you're going to be injecting so many discs because everybody over the age of 50 has some dark discs, which means you're going to inject a lot of people that never need to have surgery and never should have the injection. So that's the hardest part, is working out, okay, where along this process are you going to inject discs? You want to inject them early for it to actually work, but if you inject them too early, you're going to inject a lot of people that should have never had it and never actually needed it, because the disc could have healed on its own and the pain could have gone away on its own. And you may inject it, and then in 2 months they may be doing better, and you may claim credit, oh, the injection helped them. Well, no, they probably would have just gotten better on their own anyway. And so that's the difficulty in working this out, is where exactly do we inject the disc, what stage along this cascade, how long do people have to have pain ahead of time before you do it, and then what exactly are you injecting, which part of the disc are you healing? It's a complex situation. I have faith in the human brain. We have solved so many problems, it's a miracle. The type of surgeries we do today compared to surgeries done 20 years ago are miraculous, and much less 50 or 100 years ago. It's the advancement in medical care and just human development. No, don't even start with the airplane and the television and the internet. But the amount of advancement in the last 100 years is so incredible. I don't doubt that in the next 100 years, we're going to have a biologic solution that is going to work. But it's a complex situation that when you really look at the full spectrum, we are so early on that spectrum. We are totally in its infancy. We don't really know enough at this point to have any type of solid treatment. It's early, it's experimental, and I really respect the patients who are willing to undergo these procedures now. One, they're desperate, they're in a lot of pain, and they don't want to have a fusion, and they want to be helped. I fully respect that. But it's also they're early pioneers to where this process and this science is going to end up, because in 30 to 40 years, it's going to be dramatically different. And I truly believe it'll be significantly better, and we will come up with a solution. So that's the basics of spinal injections. We talked about epidurals, different ways to do it. Transferaminal is most common, but also a caudal from your tailbone or a translaminar right down the midline. Facet joint injections, which can help with some people's facet joint pain specifically. Doing the disc itself, we can't inject, but we can generally inject around the disc, although injections of the disc are being done more and more often. The typical substance injected is a steroid, an anti-inflammatory steroid. It's typically been shown that you can have 4 or 5 epidural injections a year for several years and has not been shown to have a deleterious effect. The California Orthopedic Association came out with a whole review and meta-analysis and position statement several years ago that said this was basically safe. Although some people, one steroid injection can trigger an immune reaction or an allergic type reaction in their body that might throw their whole system off. So everybody's different, and there's always a risk with any type of procedure. But in general, as long as you don't expect too much of the injections, they're not going to cure pathology. It's not going to heal a disc herniation. Generally, what they do is decrease pain and inflammation to buy us time to let our body heal and to get our muscle strength up to help ourselves. The next podcast we'll be doing is on different types of injections as far as stem cells, PRP, the steroids. So check back in. That'll be out soon. If you have any questions or issues, please feel free to reach out anytime. You can check our webpage, watkinsspine.com, or our app, the Back Doctor app in the App Store. Thank you.